Hello, and welcome to the brand new series of the Cytokine Signaling Forum podcasts, focusing specifically on axial spondyloarthritis. We'll be bringing new episodes on bi-monthly basis, and we'll also be supplying you with monthly slide decks to help you keep up to date with the latest research and publications in the field of axial spondyloarthritis. First of all, allow me to introduce myself and my co-host. I'm Professor Baraliakos from the Ruhr University of Bochum in Germany. And today I'm joined with Dr. Mehta from the National Heart, Lung and Blood Institute, National Institutes of Health, Bethesda, USA. If you want to find more about us and the papers that we discussed today, please head over to the CSF website, which is the URL www.cytokinesignaling.com.
Thank you so much. So today, our first paper that we're going to talk about from Van Helder and colleagues investigated upadacitinib efficacy in SPA. The second paper was authored by Witrand and colleagues and looks at factors associated with drug-free remission in early onset SPA patients. And finally, in Glintberg et al., they focus on the association of bDMARD treatments with hospital-acquired infections.
Thank you, Nehal. So let's go over to the first paper entitled Efficacy and Safety of upadacitinib for Active Ankylosing Spondylitis Refractory to Biologic Therapy, a double-blind randomized placebo-controlled phase 3 trial. Regarding the study background, we know that we still have limited treatment options for patients with axial spondyloarthritis, especially when it comes to biologic bDMARDs. And we also, in the meantime, do know very well that JAK inhibitors have emerged as alternative oral treatment options for active patients with ankylosing spondylitis based on the clinical trials that we have seen already in biologic bDMARD naive patients. And in the current study, the authors aimed to see and evaluate what happens regarding efficacy and safety of upadacitinib versus placebo in a biologic bDMARD inadequate responder population with axial spondyloarthritis, including both patients who have been pre-treated with a TNF blocker and IL-17 inhibitor. Regarding the methods, I already mentioned that in the title, it was a double-blind randomized placebo-controlled phase 3 trial with patients in adult age with active axial spondyloarthritis who met the modified New York criteria, obviously, and they had to be inadequate responders to 1 or 2 biologic bDMARDs. This means either TNF or IL-17 inhibitors. The selection was made, or the allocation was made 1-on-1 to either oral upadacitinib 15 milligrams, the approved dose already daily. They included 211 patients there, or to placebo. We had 201 patients in that group for a 14-week double-blind treatment. The key endpoints were the usual one in the meantime in the field of axial spondyloarthritis, ASAS-40, and this was measured at week 14, and there were secondary endpoints such as ASDA, SPARC, scores also for inflammation, and the enthesitis scores, including masses, total back pain, nocturnal pain, and BAS-Phi, the functional index. Now, regarding the results, most of patients had previous exposure to 1 biologic bDMARD. This was a TNF blocker. Obviously, 74%, 75% of this of the population was in there. And this was followed by 1 IL-17 inhibitor, 13%, 2 TNF blockers, 8%, 1 TNF blocker, and 1 IL-17 inhibitor, 5%. And just a minority below 1% had 2 IL-17 inhibitors. 77% of the patients discontinued prior biologic bDMARD due to inefficacy. This is an important information because the other about 30% had an intolerance. This means they didn't necessarily have to have purely failed the treatment of a biologic bDMARD before. So we can say that 8 out of 10 patients indeed were true inadequate responders, and all endpoints were met at week 14. And that's the important message of the paper. So this means, and that's now coming to the main outcome, that already having said that the endpoints were met, that we had a significant difference of the ASAS-40 responders in patients in the upadacitinib group as compared to placebo. The numbers here were 45%, a remarkable number, versus 18% after 14 weeks only. Obviously, this is highly significant. There was also significant improvement in other outcomes, as mentioned before, quality of life, spinal mobility, enthesitis, with the and also with MADRS. We also had ASQOL health as a health index in BASMI, and including which were included in the significant improvement under upadacitinib. Another point that I would like to make is the improvement in the objective signs of inflammation. This means high sensitivity CRP, centrally read, and also the MRI spinal and sacroiliac joint scores with the SPARC score also centrally read. Also here, significant improvement from upadacitinib versus placebo. And we, of course, also had all the other outcomes, including function and pain, which were also highly significantly differing in terms of benefit for or in the group of upadacitinib after 14 weeks. Regarding the adverse events, we had 41% of patients with an adverse event in upadacitinib group and 37% in the placebo group. This means a very similar situation, not big differences, and there was a numerical difference in the upadacitinib group in terms of serious adverse events, but this still was very low, 2.8% in these patients, without any new safety risks. So overall, regarding this trial, we can say that also in this population with inadequate responders to a prior biologic treatment in active ankylosing spondylitis, upadacitinib improved significantly signs and symptoms of the patients without any new safety signal. The treatment was well tolerated, and I think it's a very important information here that we have in front of us in terms of expanding the armamentarium of patients with axial spondyloarthritis. Overall, I guess this is something we need to know. These are very important data. As mentioned in the beginning, we lack treatment options, especially in this indication. Therefore, I believe this is indeed very interesting and important information. I don't know, Nihal, how you think about it, or if you have any other comments before we go on.
Well, that was excellent coverage. And no, I would just highlight three things that you brought up in that, real exceptional coverage of that. I would say first, the fact that 30% of these patients had intolerance to biologic therapy, and now all of a sudden they're taking a medicine that is going to reduce systemic inflammation, reduce defined activity, and the best one, it improved their quality of life. So I touch on all three of those points, that we have a group of patients who 77% had prior discontinuation of bDMARD therapy due to lack of efficacy, and 30% because of tolerance. And now you have a treatment that achieved primary endpoint as well as other things. So I think it's great.
Yeah, and I fully agree. And I think this is what we clinicians take away from these kind of studies.
Great. So our second paper is factors associated with drug-free remission in 5 years in early onset axial spondyloarthritis patients, data from the DESIRE cohort. And the first thing that I will give you as background is that according to EULAR's ASAS recommendation, really the ultimate goal should be inactive disease, or what I would call remission or quiescent disease. And currently there's no standard definition for spontaneous remission in AxSpA. So the general resolution of symptoms of disease activity is what's considered a remission. This study itself aimed to understand the proportion of patients with early disease who reach drug-free remission 5 years after their inclusion in a prior AxSpA cohort, and the baseline demographics, clinical, biologic, and imaging factors associated with that 5-year drug-free remission, and the impact of treatments received within the first 5 years follow-up. The methods were adults, 412 of them from the DESIRE study, with axial spondyloarthropathy with or without drug-free remission at 5 years. Logistic regression was used to identify association between demographic, clinical, and imaging characteristics at 5 years. Sensitivity analyses performed on patients who sustained that drug-free survival at 4 and 5 year visits, and patients with sustained inactive disease at the 4 and 5 year mark were analyzed. And before we get into the results, I just think that this is an incredibly important moment to point out that we just don't know much about these patients. So a study like this is informative regardless of its results. Patients in 5 years of drug-free remission had shorter symptoms duration. They had lower axial and peripheral disease involvement. They had lower values of CRP. They had less functional impairment. And there was no difference in extra articular feature history. At 5 years, 18% of the patients with early onset disease were in the drug-free remission, only 18%. Patients in drug-free remission versus not drug-free remission at 5 years had lower baseline ASAS NSAID scores. It was 40.6 versus 58.4, lower analgesic use, and lower anti-TNF use. And in multivariate analysis, patients with longer disease duration had higher HAQ-AS scores and ASDAS scores, and baseline NSAIDs intake scores had lower probability in being in drug-free remission. Patients undergoing DMARD during follow-up had a very low probability to be in drug-year from remission. So what about the sensitivity analyses? So what are sensitivity analyses used for? Really to understand if there's subgroup differences within these the findings. Among the 373 patients with the ASDAS CRP less than 1.3 at 4 or 5 years, 9% were in drug-free inactive disease. Symptom duration and scores were considered associated with drug-free survival, and any DMARD use within the first 3 years of follow-up was associated with inactive disease. Patients with an ASDAS CRP less than 2.1, 15% were associated with drug-free inactive disease at years 4 and 5. Male gender was associated with a higher likely to have sustained low disease activity, and CRP NSAID score at baseline and any DMARD intake decreased the probability to be in low disease activity or inactive disease. No gender-based differences were detected in the CRP groups, and sustained inactive disease or LDA, limited disease activity of 15%, was rare in this cohort. So what did the authors conclude before we talk about the paper? Lower baseline disease activity and functional scores are linked to the probability of being in drug-free remission at the end of 5 years in patients with recent onset AxSpA. So what do I take away from this? The first thing I would say is that lower baseline disease activity and functional scores actually make for an earlier diagnosis. So identifying patients early and keeping symptoms as well as inflammation low shows that at 4 and 5 years, these patients are doing better. I don't know if you had any thoughts, Professor.
Yeah, well, I think this indeed is the exactly same conclusion I would take away here. Obviously, well, it's trivial. If you start low, you may end up lower. And if you start very high, there might be some disease activity remaining there. Nevertheless, I think it makes absolute sense to remember that if we see patients early, if we diagnose patients early, and if we have the opportunity to treat them as early as possible, we are able also to bring them down to, I would say, no disease. I wouldn't say cure the disease, but bring them down to no disease, meaning obviously no activity and no treatment. But we also take away that this is something that this is not really very frequent, not very common, and we cannot really reach it in very many patients. That's something important.
Great. Thank you.
Well, we do have a third paper, as you mentioned before, and I would like to go through it before we come to another conclusion and another discussion. That third paper is entitled, Is the risk of infection higher during treatment with secukinumab than with TNF inhibitors? And this was including in the title that this was an observational study from the Nordic countries. That might be of importance also regarding not only the results themselves, but also the interpretation of the results, well, obviously, in order to compare them with different and other populations and areas of the world. So the study background, we do know that we have different modes of action. We already mentioned that there's TNF blockers, there is patients who are being treated with IL-17 inhibitors in axial spondyloarthritis, and the positioning, especially of secukinumab, which is the first and longer available IL-17 inhibitor in terms of the treatment regimen and the safety, but also efficacy results as compared to TNF blockers is still, I wouldn't call it debated, but nevertheless, it is a matter of discussion in very many studies. Of course, because we have also no comparative data for safety of the available treatments. And the study was indeed aimed to assess the risk of the key safety outcome infections during treatment with either IL-17 inhibition with secukinumab or with TNF blockers overall. And the comparison here was, and that's important to remember, the overall risk of hospitalized infections during the first year of treatment with secukinumab and various TNF blockers in patients with spondyloarthritis. This means this includes axial spondyloarthritis and psoriatic arthritis. And the risk of specific types of infections were of particular interest. I will report on that later on. So overall, and that's remarkable, we had very many patients included in this analysis. There were more than 10,000 patients in axial spondyloarthritis and more than 7,700 patients in psoriatic arthritis, starting with secukinumab or TNF blockers, and they were identified in 4 Nordic rheumatology registries. And the first hospitalized infection, once again, during the first year of treatment, was identified through linkage to national registries. The primary outcome was the hospital-acquired infections listed at the time of discharge. This means the true diagnosis at the end. The true diagnosis of the infection, what the doctors, the physicians may have mentioned as a diagnosis for infection during hospitalization. Secondary outcomes, there were the hospitalized infections listed at the time of discharge overall, and the infections in outpatient specialized care of different types. This means it includes tuberculosis, pneumonia, herpes zoster, fungal infections, urinary tract infections, and erysipelas. Now, the incident rates with the 95% confidence intervals per 100 patient years were calculated. There were adjusted hazard ratios that were estimated, and also the sensitivity analysis were done for investigating confining by indication. Now to the results during the first year of secukinumab treatment versus adalimumab and other TNF blockers. And I mentioned adalimumab here because you will see there are some differences as compared to the other TNF blockers. For the risk of hospitalized infections, we have 3.5% in the secukinumab group versus 1.7%, half of it in the adalimumab group. And the risk for the other TNF blockers, it fell somewhere in between. The incidence rates were for hospitalized infections were 5.0 per 100 patient years for secukinumab and 2.3 for adalimumab, with the rates for the other TNF blockers also falling somewhere in between, especially for etanercept versus secukinumab. For the other TNF blockers, there were no statistically significant differences for secukinumab, I have to say. For the combination of axial spondyloarthritis and PSA, a higher risk of hospitalized infections was observed during the first year of treatment with secukinumab versus adalimumab. So the combination of all the indications of spondyloarthritis were put in here, and there was indeed a higher risk again for secu versus ADA, and the incidence rates were generally higher for PSA versus AxSpA, but they had similar patterns across biologic DMARDs. Secukinumab was associated with higher hazard risk for hospitalized infections versus adalimumab, and the combination of TNF cohorts with adalimumab as compared to secukinumab showed also similar results. So there was indeed a class effect here that we're talking about. And similar rates were also found for pneumonia, for upper urinary tract infections, fungal infections for secukinumab. Overall, a higher rate of pneumonia and lower rate of fungal infections were observed for infliximab versus secukinumab. This means the IV treatment here, that we know that we need to take that into account since the mode of administration is different. The numbers of events for herpes zoster, erysipelas, and tuberculosis were too low as expected, since there's always also especially for TB, a screening before starting treatment. So this was too low for allowing for meaningful comparisons. And there was no registered recurrence of TB during treatment with secukinumab. Well, again, I would say as expected. So overall, at least in that cohort combination of data collection from the Nordic countries, there was a low frequency of hospitalized infections during treatment with secukinumab or TNF blockers in both axial spondyloarthritis and PSA. This was an overall frequency which was very low, but in clinical practice, indeed, we did see, or the colleagues did see, a double absolute risk of secukinumab in patients for the first year of hospitalized infections versus adalimumab, while the other TNF blockers were falling in between. At least to me, and this would be my final remark here, at least to me, this is pretty reassuring that what we have always said and we believe and also claim still is being backed up by this data. This means biologic DMARD treatment is safe. There is still adverse events and infection risks that we have to take into account, but the overall numbers are extremely low. There seem to be some differences in terms of the mode of action that we see in these Nordic countries again, but still I would say that these differences may allow for some, let's say, risk stratification between patients, but we are still nevertheless on the safe side. Now,
I agree. I think it's pretty clear by this paper that the benefit outweighs the risk.
Thank you. Yeah, and again, these data are important because we have in numbers what we believe we see and practice in daily practice, right?
Yep, completely.
Well, then we've come to an end of our webinar and of recording. Thank you very much for joining us in this AxSpA podcast, brought to you by the Cytokine Signaling Forum, CSF. We really both hope that you enjoyed it and you found it useful. If you did, don't forget to subscribe to our channels on YouTube, SoundCloud, or wherever you get your podcasts from, so that you don't miss any future episodes. If you want to read more about what we have discussed today, head over to cytokinesignaling.com, where you'll find detailed summary slides of each of the papers. And with that, I would like to conclude and say see you next time from both of us.